Ladies and gentlemen, please welcome BCRF's Scientific Director and the Medical Director of the Evelyn Lauder Breast Center at Memorial Sloan Kettering.
Wait, where's that voice coming from? Who's doing that?
Dr. Larry Norton.
Yeah, wave your hand, whoever's doing that voice. Great job, thank you.
Thank you.
Thank you. You know, I've got to say, that video has several versions. I'm going to sit down. You can still see me. Actually, at my height, whether I'm standing or sitting, I'm the same height. Actually, don't laugh that much, folks. You know, but you know, it's kind of everything in there because it's about the science and it's about what we have to do, but it's also about. It's about medical care, but it's about doctor-patient relationships, which I think is that's how it all starts, you know, how you get the information, how the person gets the information, with the impact on the individual. And that, frankly, I think is one of the things that we got to guard very, very carefully in this new era of precision medicine and advances in medicine where the zeitgeist is saying it's all in the data, it's all in the molecules, and a lot of it is in there, but the patient communication part of it is critical. I mean, we're all humans, and we have to talk to each other, and that's why it's especially nice to recognize, this is the way I'm getting into it, our new dame, Leslie Fallowfield, who's been a friend of ours for years and is one of our new grantees from the Brighton and Sussex Medical School in the UK, has received knighthood, that's what dame means, and we're all extremely proud of her. We have actually 15 other new grants this year, and it's all around the country, all the way from Boston to Seattle. I won't run through the whole list of the institutions, so we're expanding actually in size as well as constantly improving in our quality and our driving toward the ultimate goal, which is the eradication of cancer throughout the world. We're an international group. And while we're on the topic of knights, we also have Sir Paul Nurse, who's among us somewhere. Where are you? Wave your hand. Okay, there you go. I thought it was your voice, the voice of God coming down. And he's the recipient of the new Sir Elton John. We have a lot of knights here, you know. The Sir Elton John Award, which has been endowed generously by Leonard Lauder. And so that's a critically important and wonderful award that in honor of Elton, who's been a supporter of ours for well over a decade and has helped us raise an enormous amount of money in our evening benefit that's in April that you're all invited to come to and buy a table because it's critical for the success of the scientists that you see before here. We have a few other honorees I just want to mention. Bill Kalin, who's been a long-time grantee, I guess for about a decade or so, is over there. Stand up for a second, people can see you. All right, good. Recipient of the Lasker Award this year, which is the equivalent of the American Nobel. Paul has the actual Nobel, International Nobel, and we also, Mary Claire King just won it a few years ago too. Where are you, Mary Claire? Over here as well. These are the highest awards in America for scientific achievement and other things, and it's really a remarkable thing that we have such a brain trust in front of us. And if it weren't for the fact that have my own personality disorder, I would be fearful to be in the company of all these people that are so extraordinarily accomplished in their field. And again, you notice how I'm doing transitions from one sense to the other, how cleverly I'm doing this, you know? And while we're on the topic of really excellence and wonderful people, I'd like to invite to the stage the people that are going to join us, and I think you have, I don't know if it's going to be in this order per se, that you know, before us here. Judy Garber, who you see here, has now assumed the position, come on up, Judy, has assumed the position of the head of the Scientific Advisory Committee that's going to review grants and make recommendations and do steering. Remember, we do things very differently here. We identify excellence. It's not just a competitive grant thing where they come in the mail or by email and then we pour through them. We go out and we seek the very, very best. And we're not ageist. We have people right at the, you know, have had a long history of accomplishment, people right at the beginning of their careers. We identify excellence. Judy is assuming the role that, as you know, Cliff Hudis has had for many years, working side by side. Cliff is still part of our group. He's now going to be heading a board of external advisors. That's just really in formation right now, but he's gone on to become the CEO of the American side of Clinical Oncology, which is an organization that we've also been supporting in their grants program for years. So it all marries together in a very, very productive way. And Judy is in Boston at Dana-Farber, is a real expert in hereditary breast cancer and many other things, triple-negative breast cancer and many other things that we'll get a chance to talk about. Who else do I have here? Chuck Peru is the recipient of the Rose Award this year. Come on up, Chuck, from UNC. And he's a very good example of somebody who we supported very early on in his career. I think you said you only had like 4 years into your independence as an investigator. Chuck has really kind of revolutionized breast cancer thinking and management in a very, very real way that he'll also get a chance to talk about by identifying that breast cancers are not one disease, but are intrinsically different diseases with different gene expression, which means different biological behavior, different response to therapy. We're still learning an enormous amount about this, and it's been a real adventure, and it really all started with the observations that Chuck made, looking at the data and letting the data organize itself, and also having an enormous amount of intellectual courage, I must say, in those days when this was not a popular idea. And the other, I have to look up here to make sure. Oh, yes, Sylvia, are you here? I know she got stuck in traffic as I did, and so we're all kind of short of breath. Who's the head of radiation oncology at Cornell, New York Hospital, and is obviously a world expert in radiation therapy for everything, as well as breast cancer, but has gotten heavily into the field of immuno-oncology. Well, again, one of the hottest areas, and we have many experts here who've been working in this area. I would mention that all these people are supported by the wonderful generosity of a number of individuals who have given grants, named grants that in their honor. Judy is the Gwendolyn and Joseph Strauss Core One Charitable Fund. In that regard. Chuck has been supported by the Hertogs and Susan Hertog, who is actually also writing a book, if I may say so. I'm probably letting something out of the bag here on the history of the Breast Cancer Research Foundation and interviewing people. We've had wonderful conversations, and she's speaking to many other people as well. And the history of this organization is really fascinating. You know, it's kind of one of those things you don't know how interesting it is until you actually start talking about it, and you realize what a fascinating adventure that we've had. And Sylvia is getting the Ultra Breast Beauty Award for her astonishing work, and we're all very grateful to these supporters, and for my wonderful scientists who are arrayed around me, and my wonderful scientists and physicians who've joined me here to speak about their work briefly and then answer your questions. So you're the Rose Award winner, Chuck. You got to start. And the theme here is, which we chose this year, is very, very specific for this, which is when you're right in the middle of something, you tend to focus in on what you're doing at that time and looking a little bit forward in the future for how you're going to make progress. And this is a very good point, I think, in the history of breast oncology, of oncology in general, of science in general, to just stop for 30 minutes, 60 minutes, however long we have, and say, where were we, and why is this moment different than where we were, and because of that, really, where are we going? And so I want to start, Chuck, by talking about breast cancer as one disease, all right, which is where we were not very long ago. It was a cancer that was in the breast, and that's what we knew about it, and that's the way we treated it. And I don't think we're thinking about that way anymore, Chuck. What do you think about that?
We're certainly not thinking about it that way anymore, and I think breast cancer was one of the first cancer types to enter into this world of personalized medicine. As you said, I don't know, 20, 30 years ago it was one disease, but then along came the estrogen receptor, and suddenly we realized there were at least two kinds, right? And then came along HER2, and now there's three kinds. And then some of the work I participated in where we were able to now use the whole genome of data, so we might throw this word around, genome. It basically means we're looking at all your genes at once. There's 25,000. Are they all good? Are a few of them misexpressed? Using some of these new tools that we have, it's just still amazing to me that we're able to look at your genome now in a day, as opposed to many years ago when it took years, or it wasn't even possible to do that. So by using this, we could now see that breast cancer is not even 3 diseases, it's probably 5, 6, or more, right? And this is really important because now we can look at the biologic differences between these different diseases. We can try and figure out what are the genetic drivers of each of the disease, and then couple that with the right drug. So I think through using these new tools, like a new microscope, we can better describe the disease and better treat the disease.
Right. Well, we're talking about genes here, and this, Judy, differentiate between like genes in the cancer and genes that you're getting from mommy and daddy. and how the genes you're getting from mommy and daddy relate to what Chuck just said?
So those 25,000 genes in your blood or your saliva where they can look at white cells, those are the genes that you were born with. And certainly thanks to Mary Claire King over there and several others, Mary Claire's already been mentioned, we've come to recognize, which we didn't when we thought of breast cancer as one gene, that it was possible to be born with a change in at least one gene that could increase the risk of cancer. So those of you who've had genetic testing have had a blood test that looked at your usual genes, your normal genes, the ones that are in all your cells, to see whether there was a mutation present. A mutation is just an alteration that changes the function of the gene. That might increase the risk of breast cancer, ovarian cancer. Now, of course, we have mutations in genes for many different cancers. In the tumor, when it starts to grow, genes are also changing, and the accumulation of mutations in the genes of the tumor can really help determine its behavior. And that behavior changes over time, as anyone who's had to change treatments might realize that a tumor that was sensitive to something might change its genes as one way that it would then change its sensitivity to the treatment that you're getting. So Chuck has focused primarily on looking at all the different changes in the tumor and the story that they're telling that might help choose the best treatments or figure out why a treatment didn't work and help guide you to something else. Ken Offit, Susan Domchek, Fergus Kaut, and Mary Claire and I have been thinking about the genes primarily that started you on that path in the first place. Sometimes those genes also determine how the tumor might be likely to behave. So we use all the information, not just the ones that we were born with.
Well, certainly, well, it just, having this event as many years we've done it, I don't know how many years we've done it, it's like a time lapse when you really think about it, because you can focus in on, I don't know if you ever saw the Steve Jobs movie, the recent Steve Jobs movie, where they just focused in on his presentation of new products as encapsulating all the complexity of his life. And so this meeting kind of, every year you can sort of, what has happened over this last year where we were, thinking about how we started this when estrogen receptor was new and exciting, and the idea of hereditary breast cancer was, yeah, we knew certain families seemed to have a lot of breast cancer and no idea why, to where we are now is just astonishing, frankly. And one of those astonishing things is that many of those abnormal genes, are also making abnormal proteins, and many of those abnormal proteins can actually be identified by your immune system as being abnormal, not being normal. And we've known that for a long time, and then there's been a revolution in our thinking about what we can do about it. And Sylvia, you want to talk about that a bit?
Yes. So it turns out that for the time cancer has established itself, it has been capable to escape the control of the immune system. In fact, the immune system is our best friend in protecting us from cancer. It's capable to distinguish normal cells from abnormal cells, whether it's a bacteria or is a transformed cell, all the time. Unfortunately, particularly when we're aging, the immune system gets a little weaker, and we accumulate more transformed cells. And as a result, you get to a point where transformed cells are more capable to grow, and despite the attempts of the immune system to reject them, establish themselves as a tumor that gets detected. So at the time cancer is detected, it's not only a failure of the immune system, but it's also increased capacity of the cancer cells to escape the control of the immune system. So you have very healthy, as human beings, particularly, I see all the time these women who had a very good diet and exercise, had a very nice, normal life. They've done nothing wrong, and now they have breast cancer. And they always ask me, how is it possible that I got breast cancer? Their immune system is quite fine, it's just selectively blind for that tumor, for that cancer. So an interesting new set of strategies coming out and being quite successful in other tumors so far, but getting to become successful in breast cancer as well, is not only to target the cancer, but to help the immune system contribute to the cure and recruit the immune system to fight the cancer. So it turns out that, in a small lab and initially on preclinical, on animal experiments, and then slowly and gradually getting into human beings as well, we found that, and from the very beginning supported by the Breast Cancer Research Foundation, we found that radiation therapy that is not usually used to stimulate the immune system, quite the opposite. We all think that radiation immunosuppressed, particularly when it's given to the entire body, the local radiation much less. But it turns out that you can harness radiation to target, particularly metastatic disease, one metastasis, and help generating new antigens, those new proteins that Dr. Norton was alluding to, and maybe reawaken the immune system and make the cancer something seen as non-self and help the rejection of tumors.
How are you exploiting that, Sylvia?
So we're exploiting it. By itself is really not capable. Otherwise, every time we give radiation to palliate one metastasis, we will see these fantastic results, right? But when it's combined with some of the new immune therapies that are coming to fruition, and they reflect 50 years of incredible basic science research in cancer immunology and signaling in cancer immunology, as well as the most recent findings on some breaks the immune system has and how to remove those breaks. So maybe when combined with those approaches of immunotherapy, radiation can make a difference. And we're already seeing results in melanoma, in non-small cell lung cancer that suggest that that is the case. So you just use radiation to perturb the tumor in the radiation field and somehow create an inflammation of that tumor, a series of signals that elicit and recruit the immune system to that specific tumor, and then you may try to convert the individual specific tumor into a vaccine, meaning that now the patient acquires the capacity to reject the tumor and also possibly to reject the metastasis at distance, a capacity he would not have had just with immunotherapy alone or with the radiation alone.
Chuck, I was fascinated by something you presented yesterday. We had a scientific symposium yesterday, most of the day, where we had presentations and we had a lot of discussion about the fact that there's white cells that we find in the cancers, or at least we find genes associated with white cells in the cancers, and that has implications. You want to talk about that a bit?
Certainly. So we find there are many cancers that have immune cells already infiltrating them, already sort of attacking the tumor, and as was just discussed, they're actually, in many of these patients, sort of being held back, right? But what we can see is, even in the absence of all these different therapies, tumors that have immune cells in it, that already portends a better outcome for that individual. And so it's like the immune system is there and primed and trying to go, and it's going a bit. And we need to learn better how to take advantage of that, right? I think other things we're learning is that also drugs like chemotherapy and maybe trastuzumab against HER2 that we could argue have other mechanisms of action probably also have an immune component as part of their efficacy. So it's really starting to pervade many of these different treatments.
Judy, we've heard that sometimes people with genetic susceptibility, hereditary susceptibility to certain cancers, to breast cancer, have a preponderance of triple-negative breast cancers, we do see changes in the white cells in that regard. I mean, what do you think the linkage is there? Do you think there's some kind of linkage between this genetic predisposition and the appearance of the white cells in the tumor? Are there differences? We're going to start to get deeper really quickly.
I already asked you the hard questions already.
No, I've got hard questions for my colleagues as well, and they have hard questions for me, so we'll go on.
I don't think we really know yet why the BRCA1 associated tumors, for example, which are so often triple negative, seem to have more immune cells in them. Nadine Tung and Stu Schnitt showed that last year. We can see this, but sometimes what we observe really just stimulates more questions. What are they doing there? And are these the tumors that will benefit more from immune therapies? As Chuck said, they already are tumors that seem to do better from chemotherapy. You'd hardly think that would be the silver lining of your BRCA mutation, but there are some data that those tumors are more sensitive to killing by chemotherapy. Maybe it's their DNA repair defects that so many people in the group work on. Maybe it's that those same DNA repair problems generate more abnormalities, more neoantigens that Sylvia mentioned, that they are making new proteins that are then new possible stimulants for the immune system. This is, for me, total speculation, but I would tell you many other people in the room have data that would speak to these issues.
Yeah, and I think one of the things to emphasize here is that some of my scientists are cringing. I could feel the cringe, because we're simplifying, intentionally simplifying some of the enormous complexity here. Nothing that's said is wrong, but it's that there's enormous complexity that's going on here. For example, we have data that exists among my colleagues here that some of those white cells actually stimulate the growth of the cancer as well as attack the cancer. There's a yin-yang going on. And we do know that inflammation seems to predispose to many cancers: breast cancer, prostate cancer, lung cancer. You stimulate white cells every time you smoke a cigarette, and those white cells may actually be growth promoting. So that it's not so simple. I got to tell you, I like the idea that it's complex, because when you have a lot of pieces, when you have pieces of information that don't necessarily fit into a nice little package, that's an opportunity to make advances by seeing how it all works together. When in the history of science, and you go back centuries in the history of science, it was thought that everything was really very, very simple, and we didn't have to do any further inquiry because all the pieces fell together. Newton's universe, very, very simple equations, very simple mathematics, gravity, and so on, and you could explain the entire universe. We didn't make progress for a long time after that because we thought we knew the answers, and obviously we didn't know the answers. Bad things still happened, people still got diseases, people still got cancer, and we didn't have all the answers. So I love the emerging complexity of this story that's coming through. And all of this really sort of links together as pieces of a very, very big puzzle that the brain trust that's up here is working on, as well as many of the topics that you've heard about and you will be hearing about in subsequent years. Blue skying it. Let's just take it as we're getting ready for audience participation here. Let's just imagine in a perfect world, all right, with all the science coming together, everybody working together, all the sufficient funding, and all the serendipity and all the ideas sort of gelling. Where do you think we're going with all of this? I mean, where in your fantasies do you think we are going with? And obviously we say the eradication of cancer, which is what we believe, but in your own specific areas, where is genetic? And I was just going to go down in that order. Where is testing for hereditary cancers really leading us into the next step?
Well, so let's see. So, we can already today, compared to the beginning when Mary Claire taught us about BRCA1 and 2, then she taught us there were many other genes as well, and many of the people in this room found those genes. So already we can find more people who have increased risk based on their genes. There are also people who have risk based on less powerful genes. We haven't really exploited that yet, but we're coming. In my blue sky, it would not only be the genes. We should be able to find risk based on many other factors that contribute to risk. We know about the difficult ones like, obesity, exercise, all of those. But there are other intrinsic factors. We'd be able to predict better. And in my blue sky, we'd be much better about prevention. So maybe some of these immune therapies will really translate into preventive vaccines. Why not, as long as we're dreaming? And ideally, there would be other strategies, health behaviors, but also medications that you could take to lower your risk of cancer that you wouldn't mind taking because they wouldn't cause hot flashes and other side effects that we don't want to have. So in my blue sky, it's all about identifying risk and prevention. And these things are all possible in my lifetime.
Yeah. Chuck, where's it all going? And what about Aurora?
Well, Aurora is a great new BCRF-sponsored initiative to study metastatic disease, where we desperately need to make faster progress. As I mentioned, we have some amazing tools nowadays, from genetics to imaging to treatment, and we're getting bombarded with complexity and huge amounts of data. And so I think a lot of the future in the blue sky is going to be in computer modeling or computational modeling to assimilate all this data and to make predictions, and using techniques like machine learning, where if we can utilize all the patient medical records and clinical trial data and the sequence data on the patient's tumor and their germline, we really want to link it all together to make some of these predictions. Today, we sort of pick one of the types and use that one type to make most of the decision making, but we should really be using 4, 5, 6 different data types, linking them together and to use that, and I think we can do this with many of the computer tools that are being developed right now.
One of the really exciting things to me, exciting yesterday's Symposium, is how much of BCRF activity is now collaborative among the investigators and really throughout the world, and involving patients. In terms, we heard a really, I thought, very exciting presentation. Nick, you might want, if you're some here, you might want to mention it. I don't know where you are, Nick. But we're gathering an astonishing amount of information about cancer now in ways that we couldn't do before. The difference is because, first of all, the comfort people have with actually volunteering their tissues for analysis and medical records, I think, is a very, very important sociological change. There used to be much more resistance to this. Now we're seeing that change. But also the speed and the lower cost of actually doing the molecular analyses is changing everything. But it's generating an astonishing amount of information. And in that regard, I want to mention another BCRF initiative, is that we are, through the generosity of supporters, starting a mathematics program where we're going to bring in true, basic, theoretical as well as applied mathematicians to the cancer question to see what creative things can be done with the data so that we can analyze it and understand it in a better way.
Sign me up. Can I get them into my lab?
Yeah. Because right now what we're doing is we're collecting enormous amount of information. We're kind of cataloging it, which is kind of where we were with astronomy before Kepler. We knew all the positions of the planets and the stars, in intimate detail, but there wasn't any one concept that brought it all together, and it was the theory of universal gravitation, really, and Kepler's laws of motion that brought it all together so we could understand astronomy. And we don't really have a universal law for biology yet. We don't really understand biology. It's going to be more complex. But it's got to be understandable because it really is rather predictable. I mean, most people in this audience have one nose, two eyes, two hands. We come out of the womb pretty regular, and that's an element of predictability, right? So with all the complexity of these gene-gene interactions, there's got to be some laws that sort of tie it together. But we don't know yet what those laws are, and bringing in a whole group of people that have not been brought into the problem yet, which is the real mathematics people, could be very, very productive. And so this is a BCRF initiative. We're going to start off with a meeting. I guess we're going to start the granting in January or very, 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 very soon in this regard, and we're developing a program. So we're going to collect the data, the worldwide initiative in metastatic disease, the work that's being done in the various laboratories, including Chuck's, who's leading the molecular analysis in that regard, and really innovative mathematical thinkers to see what we can do with the data. And that's another thing that we're approaching. So where is immuno-oncology going? Where is radiation oncology going? I mean, let's start basic here, and then your particular focus then on immuno-oncology. Where is this all going?
So radiation oncology is trying to figure out how to optimize this tool in view of all the progress we have made in understanding different cancers, how to make it much more personalized on the disease and the patient. So before we're giving 7-8 weeks of radiotherapy, now we're moving into 3 weeks and maybe even 1 week of radiotherapy. We learn through technology. We can reduce more and figure out that we figured out it's safe. We select the patients much more carefully. Maybe there are even subsets of patients that do not need radiation. So a lot of personalized oncology going on in our field, and certainly a lot of attention on treating normal tissue, heart and lung, with different techniques and modalities and different forms of radiation. But I think, if you want to dream the future, is really the integration of all cancer biology getting to fruition to the single individual. When patients have cancer, they show us a snapshot of what has happened before. We just somehow are confronted with the reality of when they are diagnosed. But what they have is the expression of their own genetic background, as has been mentioned by Judy, as well as the type of tumor they've developed, which is a crosstalk of their immune system with the tumor, as we said before. So there are already three things moving at the same time. And when we are in the course, for instance, of the crosstalk of the immune system with the tumor, is really what we have. We're not before or after, or we will become after we treat. And how the treatment we give can interfere with that snapshot. So integrating all three information, the genetic of the patients with all the tiny little differences we have, those polymorphisms, those SNPs in our not only immune system, but in all our genes, integrating the personalized genetic makeup of that patient, the type of tumor that now we can interrogate so much better, and the type of immune response or deficit of immune response to that specific patient at that specific time in the course of the disease is going to be the future. And yes, we need a lot of mathematics, and we need a lot of modeling, and we need a lot of other tools from other sciences to help us also work on randomness, because there is also something called bad luck that happens and things don't align the way you expect, and taking that into consideration to really personalize on that specific individual and design a treatment that in my dreams will be completely individualized.
Wow. Two things. One, you have cards, I think, to fill out in case you have any questions. And you know, while we're talking for another few minutes, if you can fill those out, and we'll collect those, and we'll get to some of your questions. I'll probably recognize a few of you also in terms of asking questions. But something really has occurred to me that I think we ought to really talk about. I'm going to put Leslie on the spot here. She will have no trouble with dealing with this. We're going to give you a mic, which is this, which has really been hitting me over the last year. And I actually gave a little talk about this in Dublin just a few days ago, which is the complexity of the science has to be communicated to a patient, all right, in a very short period of time at the most stressful possible time in that person's life. You know, you go from a perfectly healthy person, you know, you just finished a marathon, you know, you took a shower, you felt a lump in your breast, all of a sudden your life is dramatically altered. And at that same time, you have to understand about genetic susceptibility, you have to understand about stochastic processes, which is randomness, incomplete penetrance, and all these terms are going to be sort of thrown at you in these complex ways. Your tumor is going to be sent for molecular analysis, is going to come back with reports in terms of its intrinsic subtype, which is something that Chuck and Matt Ellis, you know, here really have kind of invented and really provided opportunities for patients to learn about, as well as a number of operations that are saying these are the mutations and these are the drugs you ought to get because of specific mutations. These are commercial reports, and you're getting all of this in about 20 minutes, and then it finishes. Well, make your decision and let me know. Goodbye. Leslie, what's going on here, and how are we going to deal with this? Dame Leslie.
Dearie me, I don't know how long have I got. I think one of the difficulties, of course, is that people will come to the clinic with different expectations. And most people, just the words breast cancer actually mean a death sentence, and they're thrown into emotional turmoil by that. So anything that people are saying about the rationale, the logic for the different types of treatments that are on offer are actually set against this backdrop of extreme fear and anxiety, because at that particular moment, most patients are just actually thinking, I want to live, I want whatever treatment will give me the best opportunity of doing that. And in fact, one of the problems, I think, is that breast cancer actually is not a medical emergency, it's an emotional emergency. And that people have got more time than they realize to make decisions that are right for them. And a lot of the literature that we see about, you know, go and get your breast screening the moment you find a problem, quickly go to the doctor, because then you'll catch things early and can start treatment right away. It actually increases this notion that breast cancer is a medical emergency and we've got to act quickly, and usually act quickly with the most aggressive forms of treatment. And that's not what we should be doing. What we should be doing is actually helping patients make decisions well-paced at the right time for them. Now, one of the problems also is that if the person who's talking to a patient, and sometimes their family, of course, it's not just the patient in isolation, we don't inhabit social vacuums, a lot of people will contribute to the decision-making process. If in fact the information is not given in a sensibly paced, non-patronizing manner, people will make unwise choices about things. So we have to be clear that, first of all, it's not something that's going to kill you tomorrow unless you quickly have an operation, quickly start the chemotherapy. It's something that needs treatment, but it needs treatment that is right, not just medically, but that will fit for you. And if you don't actually get good information from your caregiver, you are prey to Dr. Google. And Dr. Google can give you some very weird recommendations about treatment. So unless our doctors are good communicators, good at actually working out how to express things in a way that's right for you, you're probably not going to make an educated and informed decision, which is why, despite the fact that in this room we have the biggest brains in breast cancer science, they still need to learn how to talk to people. Yeah. And that includes each other.
Excellent. Thank you, Leslie. I just can't, there's a Yiddish word, kvel, which is kind of a pride that you have in your children. I know many of you know the word. And I'm just kveling about BCRF, that we're supporting, research like this, and also research in terms of the, the basic biology of cancer, the genetics of cancer, and infant therapy, really having us all together in. We had a dinner last night, and it just blew me away, having so much expertise there, all working together, and all being non-competitive, friendly, working together toward a common goal. It's just, as I said last night, it's not the fulfillment of a dream, because I didn't even dream that this was possible. This is beyond my dreams, and beyond Evelyn's dreams, and Leonard's dreams, in terms of where we're going, in terms of what's happening now. So it really is incredibly thrilling.